Hi, everyone on the Surgeon app. It is my pleasure to introduce our speaker for tonight, Dr. Franco Marinello. Dr. Marinello is a colorectal surgeon at the Vall de Hebron Hospital in Barcelona, Spain. He is also an associate professor of surgery at the Autonomous University of Barcelona and a member of the executive board of the Spanish Association of Coloproctology. He has a special interest in pelvic floor disorders and is a sacral neuromodulation expert. He is the lead of the SANLARS trial on sacral modulation for LARS patients and was awarded the best paper at the 2023 ASCRS meeting in Seattle, Washington. I will now be quiet and I'll let Dr. Marilyn take over.
Okay, thank you very much, Joyce, for the kind presentation, and thank you for having me in this great platform that you have developed. I'm going to share my screen. Well, I'm going to summarize what we are going to talk about. I wanted to have a more comprehensive talk on fecal incontinence and residual neuromodulation in order to provide you with concepts to enhance your clinical practice. So we're going to talk about a little bit about pathophysiology of fecal incontinence, and then we will move forward on the mechanism of action of SNM, the technique itself, with some videos, some results, patient selection, and then I will talk to you about the trial that we published in large patients. So we all know that fecal incontinence is the loss of the ability to control or delay, which is a very key concept, defecation. And also when patients cannot distinguish the quality of rectal content and maintain nighttime control. Its incidence is about 10% of the population, which is quite high if we compare it, for instance, with diabetes. Here in Spain, 10% of the population has diabetes. So you can imagine how many people suffer this condition. So when we go to medical school or in residency, we always read and hear about this barrier theory for continence in the anal sphincters that get, deteriorated, or due to aging, due to atrophy, due to a defective sphincter barrier, such in those women who suffer an obstetric injury. And this all leads to fecal incontinence. But this theory that we have been studying and hearing about has some limitations, because it poorly explains the epidemiology in women, because not all women have an esoteric lesion after giving birth, and not all women who we see in our office are menopause or aged. And also it does not explain why men have incontinence. And it has been also failing therapeutically, especially with sphincteroplasties. Why do patients relapse after a sphincteroplasty? And it also doesn't have a correlation between the experience that we can see in our patients, because many patients, what they have is urgency. They don't lose the stool, some of them, but they have urgency. And when we think about how this works, is that we have to think that stool is not a Newtonian substance, okay? So this is an analogy that I heard from Professor Knowles from the UK, in which you can compare the rectum to a bottle of ketchup. So if you think about that, stools are not they don't fall with gravity, they don't respond to gravity laws. You need to squeeze the rectum in order to the stools to get out of it. It's just like a bottle of ketchup. You need to squeeze it in order to get it out. So this cannot be explained only by the sphincter. So we need to know that continence depends on many factors, such as colonic motility, rectal compliance, of course, the sphincteric normal anatomy. We need to have solid stools also. Any patient who has diarrhea will need to urge at some point. And of course, we need integrity of our medulla and cortex systems. So now the new concepts of fecal continence or incontinence is a network of nerves which might be altered and will have a lesion or whatever that ends up with those symptoms that the patient has. It's not only mechanical damage of the sphincter. So will electricity help rearrange all these and provide the patient with better improvement in their symptoms? Will electricity be the treatment? So we have to think that anecdotally, electricity has been used in medicine for centuries, especially the Greeks used these torpedo fish. It has some electrical jolts to treat prolapse in the anus, for instance. So when we talk about electricity or modulation, we have peripheral mutilation, which is when we give it through a tibial nerve or a vagina, and then we have the most invasive mutilation, which is the sacral neuromodulation that we are going to go through this afternoon. So S&M has turned 30 years. Right now, we're celebrating 30 years of the technique here in Europe. It's a consolidated technique for fecal incontinence and urinary incontinence. It's a standardized procedure, extended worldwide, but we know little about it, how it works. So gathering, I'm going to explain two main topics, 2 slides on the mechanism of action. It especially has been proven that S&M reduces the activation of C fibers during rectal filling, which blocks inputs to the brain so the patients can defer defecation. It has been shown to have medulla and cortex involvement when the patients are modulated. And also recently, there are studies with colonic manometries indicating that S&M can activate this rectosigmoid brake that we have that prevent feces entering the rectum. Because we have all the colonic motility is quite complex, but we have one retrograde pattern in the rectosigmoid junction which prevents feces entering the rectum. So one of the new theories is that S&M can work on this pattern and preventing feces to enter the rectum, enhancing therefore continence. But anyhow, it has been shown that it makes electrophysiological changes, neurochemical changes, central effects, which will end up increasing emptying or continence or increasing emptying of the rectum. So when we talk about sacral neuromodulation, we have to keep in mind that there are 2 types of tests. We have to test the patient because it's not a technique that works in all patients, okay? So we need to test before giving the whole therapy, which includes an electrode and a generator. It's like a pacemaker, okay? So that's how I explain to my patients. So we have an electrode connected to the sacral root, and then we have a generator. The generator is the most expensive part of the therapy. So we start putting the electrode to check on the efficacy of the therapy in the patient. So after we select the patient that we're going to talk about later, we have a test, and we can do a basic test with a PNE that it's a monopolar wire that we can implant in our clinic. And then we have the advanced test, which is the introduction of the definitive tetrapolar electrode, which goes implanted, fixed into the sacrum bone, which is the definitive electrode that is going to be placed in the patient. So if the patient has a 50% reduction in the symptoms or improvement, or even a 70% improvement in subjectively, depending on, we don't have a consensus about that, but we go through implantation to the generator. Of course, if we did a basic PNE test, we will have to implant the electrode and then the generator, okay? And if we do an advanced test, we only place the electrode and then only the generator. I'm going to show you now. Before that, there are some pros and cons, of course, of each stimulation test. Of course, if you go for a basic test, you can do it at the office. It's less invasive. It's cost effective. It has failed because you can easily remove it in your office. And of course, you don't have any anesthetic risk. but it's a monopolar wire. So basically the contact with the sacral nerve can be limited and not a tetrapolar, that you have 4 poles going through the nerve, and you cannot test it for more than 1 week or 10 days because it can easily migrate. On the other hand, the advanced stimulation test is the definitive implantation that you do with X-ray. If success, you can go directly through to the generation implantation, and you have 4 poles, better for reprogramming and programming the patient. You can do a longer testing time for 2 or even 3 weeks. But of course, it's more invasive. It's less cost effective if the test fails, because you have to take it out basically in the OR, and you need, of course, ORs to do so. So if you are starting to do the technique, I really suggest you to go through this paper in which a group of European experts in uro and colorectal gather and standardize the technique as we do it right now. And they state that there are 3 key elements that we need to focus on the surgery. First is the radiological marking, the place of entry of the electrode into the foramina, and the placement of the electrode. Of course, the target of this surgery is to have a midline sensation of the patient, where the patient needs to feel the energy of the stimulation in the midline, not going to the legs or the buttocks. And we're going to look for specific motor responses at the lowest amplitude as possible, and this benefit of having this electrode very close to the sacral root will provide an optimal effect, clinical effect, and less battery consumption as well of the generator. Before starting, of course, this is a picture of my OR where I do the procedures. You need to take care of all anti-infective precautions. You are implanting a prosthesis, so you need to sign outside the door, minimize the personnel that's entering and going through the OR. And especially you need laminar flow also, and you need antibiotics. I think it's mandatory to prescribe preoperative antibiotics following your protocol in the hospital. I don't have a preference. I do augmentin, but you can do whatever is suggested in your hospital. And of course, you have to instruct your team what we're going to do, and also the anesthesiologist. Here in Europe, or at least in my hospital, we do local anesthesia and sedation. As I was telling you before, I need to follow a midline sensation, and I do not get midline sensation with general anesthesia. So I do sedation. I instruct my anesthesiologist that at one point of the surgery, I will need the patient to collaborate with me and tell me where he or she feels the stimulation. So you need to tell the anesthesiology in order to regulate the sedation drugs. So this is how I position the patient in the prone position. As you can see here, the patient is flat. I put the legs a little bit down, like in a pileat kind of position. I try to do this in order to avoid any kind of low doses here in the sacral area, just to keep the sacrum as plain as possible. And then I separate the cheeks down to see the anal response, and I leave the feet on the air like this, just to also see the S3 or the plantar response easily. So after positioning the patient is comfortable, sedated. I start with the X-ray marking. I use a C-arm like you can have in your OR that any other specialty uses. And this is one of the most important key points part of the surgery, because this is a drawing that I use. Imagine that you see the sacrum on this side. So the place of entry of the electrode should be, if we have this is all the foramina, we have to divide it like by 4, and we have to try to stick it in the anterior and internal superior part of the foramina, like you can see in this green dot that I draw. So when you start doing an ABA image of the sacrum, you can see here how this is a foramina, This is the second foramina. This is the third foramina, okay? And this is how I use, this is a needle to do epidural anesthesia that my anesthesiologist gives me. It's radio opaque, so I can see it easily and leave it there. It's really easy to use. So I try to stick it right very close to the internal part of the foramina on each side of the X-ray. And then I go to the lateral side and I place this needle on a horizontal plane, trying to fit in those. This is the sciatic notches that you can see here. So I draw the horizontal line, and as you can see here, and it's the specific place where S3 is located according to the X-ray. But since I have to put the needle in a different direction and not the perpendicular direction due to the natural anatomy of the foramina, I go 1 inch above that point in order to enter the S3 foramina, as you can see in the picture. So after I put the local anesthesia, I scrub in, I put all the drapes, so the tissue is already anesthetized with the local anesthesia that I use, and the patient is sedated, okay? So I start doing, there's a short video, I start putting the needles, following exactly the same line, as you can see, and then you can feel it going through the foramina, that you're not knocking or touching the bone. So as you can see here, these are the two needles. You need to test at least 2 roots in order to get the best response. This is a suggestion. Do not get only one foramina, just try 2. And if it is bilateral, the better. Sorry. So that's another thing, another trick. Please do not crook the needle like this. You cannot crook the needle and go into the midline or outside. This is not the way the needle should be. They should be following exactly the line that you draw to maintain the same line and do not enter in the foramina perpendicularly or in a crooked direction. So this is another view that I wanted to show you. One little trick that you can see if you are in S3, because you can see here the needles passing through a foramina, is that this is a plane of fusion that you can see from the pelvic bones into the sacrum, where this shade here enter or gets together with the internal part of the sacral fascia, you are in S3. And also you can also see a little hump here in this picture. This means you are in S3 from a radiological point of view. You put the needle, try not to go beyond this point of the facial, the sacral fascia. Just not to perforate it. And it's not that you're going to induce a bleeding or any damage, but you might not follow the nerve. So then when you are there, you connect the needle to the little hook provided by the industry, and you start to check on the reflexes, on the motor responses. So when you are in S3, you will always get this plantar motor response that you're seeing right now, like that. It's very important that the leg does not twist, because if the whole leg twists at this point, you're getting an S2 root, which is not good for the patient because they will have pain. So you can see here also on the other side that you also get a bellows motor response. The anus contracts as well. That means that you are also doing the S4. So when you are in a needle with an S3, you will get 2 responses: the plantar response and the anal response. But if you are only in S4, you will get the perineal contraction and not the plantar response. That's the way you can see with the X-ray marking in which foramina you're in. For fecal incontinence, there's no difference between S3 and S4. Studies have shown that both responses are good, but I strongly advise you to always try to go through S2 to S3 because many of these patients have urinary symptoms, and in order to treat those symptoms, you always need to go to S3 because you get more parasympathetic recruitment there. And also, this model response should be, according to the guidelines, it should be under 2 milliamperes. I always try to go, because I'm very strict with the technique, because the technique is the most important thing of this therapy, the implantation of the electrode. I try to go under 1 milliamperes. The less energy you have a model response, the better. And this is the point where I ask the anesthesiologist to stop the sedation, and I ask the patient where they feel the energy, and they must feel it in the midline, either on the right or the left side of the anus or the vagina or the perineal region. If the energy goes to the buttocks or to the leg, you have to reset that needle. And then after you have the best response, you have to implant the electrode, which basically follows a Seldinger technique as we use for IV lines. You put a guide wire within the needle. You take the needle, you leave the guide wire. I do a cross with an 11 blade, and then I introduce the dilator in order to create a channel for the electrode, as you can see here. And after having put in the dilator, I check with the X-ray not to go beyond this point also here. That you can go with the wire a little bit further, but with the dilator not to create a false way or not to avoid perforating the sacral fascia, not following the sacral root. So when I have that placed, here you have a short video. I take out the hard part of the dilator a little bit, and I introduce the sheath just to follow the nerve a little bit more, and then after that I put the electrode following. It's a curved electrode, and it must follow the leg, okay, the curve of the sacral root following to the leg of the patient, in this case the right leg, so it has to go to the right side, okay. And then I take the 4 poles, as you can see here. This is the way the electrode is inserted. And then after I'm happy with all the 4 poles doing the responses, I check that I start extracting the sheath for the tines to open and anchor to the sacral bone. And I check that the cable doesn't move. That's very important, because if you take it out, you can move the electrode and lose responses. So after this is finished, this is the final X-ray. As you can see here, this is another trick. If you see that the distance between pole 0, which is the distal one, and pole 1 is shorter than the distance between pole 2 and 3, you are curved. This is the way you should go, okay? And this is the way you should go also on an AP vision. This is a perfect introduction of the electrode. After that, you have to tunnelize the cable, as you can see in this video. Sorry. You do the pocket. I do it on the same side of the buttocks as I implanted, on in this case, the right side. There are some teams, especially in the US, that they go to the other side, to the contralateral side. This is my practice. I'm happy with it. And then you have to connect the external battery for the test, and you introduce this part with it, and then you connect it to the lead, and then you close the wound. I'm really strict also closing the wound, and I have some bundles with microdicing just to avoid any infections. Sorry about that. So we have two types of generators available. There are two brands, industry that you can go, but especially the technology, you can divide it into recharge-free and rechargeable devices. Right now, the industry has developed recharge-free, very with batteries that last up to more than 10 years. So I think that now with these devices that live longer, we should I choose them rather than the rechargeable ones, because I don't want the patient to remember about recharging the device every once in a week or every 2 weeks, because it's a constant reminder of their condition. So I always go through a recharge-free device, but I think that rechargeable devices, which are smaller in size, can be really good for patients with a low BMI, or those patients who might need a high intensity programming and that might need a battery with longer lifespan also. So let's move to results. I think that sacral neuromodulation has been one of the most studied techniques for fecal incontinence worldwide. We have many outcomes. The first one, we're talking about efficacy of 80% in fecal incontinence and improvement in fecal incontinence episodes per week. Then you have this other study, which is really interesting because they state about a review saying that the fecal incontinence can improve between 70 and 80%, and not only in idiopathic fecal incontinence, but also in neurological disorders, pelvic surgery, and also low anterior resection syndrome. But this is one of the things that I want to show you, is that this comes from observational study, from France, in which they saw how sacral neuromodulation can augment or increase the deferring time. Many of our patients, they complain about not having time to get to the toilet. They get the trigger and they have to run. Okay, as you can see here in this observational study from France, 60% of the patients could not defer defecation over 1 minute. And after implantation, after 1 year, also including after between 9 and 15 months, as you can see here in the table, that time increased from 5 to 15 minutes in 60% of the population. So you can see this is one of the most important things that we have to tell our patient, that they will feel more time to get to the toilet, and that will reduce also incontinence episodes. So moving to patient selection, many guidelines with no clear consensus, no evidence of perfect candidate. Unfortunately, we don't have predictive manometric parameters. There are many patients variations. We do not know when to suggest neuromodulation for our patient. This is the European guideline that we use right now. It's a very comprehensive guideline. If you can go through it, it explains from the beginning to the end all the treatment and measures that you can do for the patients. Yes, they say the sacral neuromodulation can be used in these patients. They don't specifically say in which patients. And also, I wanted to share with you this paper, which was published by a group of surgeons here, colleagues here from Barcelona, and they analyzed all guidelines, including the ASCRS, ICA's guideline, trying to see if there is a kind of consensus, and there is not. Basically, the only agreement the guidelines have is fecal incontinence after conservative treatment with intact sphincters. So this is one of the key messages that I wanted to share with you tonight, is that when I consider sacral neuromodulation for my patient, of course, we need to correct stool consistency. That's mandatory. Patients with diarrhea will not do well with anything. So we need to get that Bristol stool score to 3 on 4, and fibers are my greatest ally, okay? Of course, we need to go through medication of the patient. We are surgeons, we don't know much about medication, but many patients are taking metformin, at least here in Europe, I assume also in the US. Metformin can cause diarrhea. We need to take it out, okay? And there are many other medications which can provoke diarrhea. So it's our job as doctors to revise that. And of course, we need to exclude any anatomical defects. Of course, the patient has a fistula, we need to correct it. If the patient has a prolapse, we need to correct it. And if the patient has a sphincteric damage over 100 degrees in ultrasound, we need to repair. And that's the key point now. We are only repairing those sphincters with a very wide lesion that you see, not only on the ultrasound, but also in the skin. I mean, we need to overlap that to make that pelvic floor healthy again, anatomical again, before considering sacral neuromodulation in those specific cases that unfortunately we are seeing even in 2024. Also, I always try any non-surgical treatments such as physical therapy. I think it's a very important. Our physiotherapists are doing a great job trying to enhance that pelvic floor. Tibial stimulation and biofeedback also are good measures and treatments that we can offer our patients before offering them with sacral neuromodulation. Of course, we have to think that patients with associated overactive bladder, they also are good candidates because you can treat two conditions, urgency and overactive bladder, with only one technique. So keep that in mind. And of course, after discussing patients' expectations, I think this is very important because it doesn't work in 100% of patients, and they can even have some relapses, and we need to sometimes reprogram the electrical parameters to get the patient back some improvement in their clinic. So it's very important not to offer a complete cure for the condition, but it's a good crutch, just it will help you walk through life again. Okay. So now expanding recommendation for sacral neuromodulation. Now, the thing that we have test possibilities and that all electrodes now are MRI compatible, we can go through patients with low anterior resection syndrome that I'm going to explain now, congenital disorders, neurological diseases. There's great evidence now in patients with Parkinson's disease and MS also that can be benefit with sacral neuromodulation. Also, some groups in Europe are studying sacral neuromodulation in patients with pelvic pain, such as endometriosis, and you name it. There's many things that we might even treat with this technique in the future. So now moving on to the second part of the talk, I was asked you to talk about the use of sacral neuromodulation in low anterior resection syndrome. But before that, I would like to explain a little bit about what LARS is. Well, low anterior resection syndrome includes all the disordered bowel function after rectal resection with sphincter sparing procedures. We all know that rectal cancer has evolved in the last decades, and now we're saving more sphincters. We're going down and down and down, and the robotic surgery now we can see the rectum and cut it and do very ultra low anastomosis. So these patients are not only living longer but also living with the sphincters. And of course, the pathophysiology of LARS is multifactorial. There is no one specific cause. I will explain that in a minute. And these patients really struggle with their daily lifestyle. And let me tell you, it's more prevalent than you think it is. As fellows, we only focus on the cancer and trying to save that, not getting a leak and all those things. But these patients, when you see them afterwards, they're really, really, really suffering. So according to the pathophysiology, as I was telling you before, it's multifactorial, okay? You have an autonomic denervation when we take that splenic flexure down, when we cut the inferior mesenteric artery, when we cut all that holy plane, all the nerves go into the rectum, we get an afferent sensory loss of the rectal reservoir that we use, which is the colon, actually. We also have a pelvic radiation, which can induce enteropathy or other changes in the pelvic muscles. And of course, the stoma that many of these patients have, the ileostomy that they have, can also produce some changes in colonic motility and dysbiosis and SIBO and you name it, and colitis. But I'd like to tell you that LARS, when you specifically study these patients and you ask them, really ask them what their complaints are, you have two different patterns. Of course, they can be mixed sometimes, but some of these patients will complain of a storage pattern in which they will have urgency or incontinence, and some of them will have an evacuatory pattern in which they will cluster, go many, many, many times to the toilet and not finish, okay, 15, 20 times a day sometimes. They also can complain of ODE, ODS, or constipation, but also these patients complain about pain, tenesmus, they have mucus, they have blood discharge, and they can also have extra digestive symptoms such as urinary incontinence and sexual disorders. So this, as you can see, it's a quite complex syndrome, and our patients deserve to get treated. Among all the treatments that you have available for LARS, sacral neuromodulation has shown high success rate in systematic reviews, in retrospective studies, and case reports. There are not clear recommendations, of course, not a first-line treatment, but due to this and not having a really well-designed study, because they were saying, okay, let's try. Remember, before talking about LARS, people were implanting electrodes for these patients, just referring it as fecal incontinence after rectal resection. So basically, this is what we are treating. We do not recommend this therapy at the beginning. We have different tools that we can use. This is the latest guidelines that we use here in Europe. It's made by a group of experts in Europe, and I really suggest you to go through to get a good idea how to treat these patients. But anyhow, we, under these not clear recommendations and following the success rate, we designed the SANLARS trial, which was a prospective randomized interventional multicentric study. It was done here in 3 hospitals here in Spain. It was double-blinded. Neither the patient or the investigator knew where the randomized arm of the patient. It was basically done in 2 phases, following our standard clinical practice, which is the test phase with the tetrapolar lead placement, and then the second phase placing the generator if the phase 1 was positive. And then we started a crossover model just to see how the patients were improving or not with the modulation. So basically, this is the methods that we use. We saw the patients in the phase visit. We implanted the time lead. We did a test for 3 weeks. If the patient had a 50% reduction in the LARS score, we randomized the patient after permanent implantation of the generator. Some of the patients left the OR with the generator on for 4 weeks. Then we stop as a washout part of the study, as you have to do in all crossover studies. And then we we disconnect it and off for another 4 weeks. And after that, we left it on for the rest of the study. And we checked the patient at 6 months and 12 months. The other group was the opposite. The patient left the OR with the generator off. And after the washout, we switch it on, and then after 4 weeks we kept it on. The investigator and the patient did not know. It was the nurse who did the randomization of the patient. So we wanted to control if the patient was the own control of the part, just to get a better results. So the inclusion criteria was anterior resection with preservation of the sphincters by any approach, with or without preoperative radiotherapy, patients with major LARS, which the score was above 29 points, and more than 1 year after the last surgery. That means after the ileostomy closure or the rectal resection, if no ileostomy was performed back then. The primary endpoint was to verify the improvement with the LARS score treated with sacral neuromodulation according to the test weight, which was set at 50% reduction, and if that improvement was maintained after 1 year at 40% when the generator was implanted. And then we, as secondary endpoints, we compared the fecal incontinence, SANLARS score. We did a bowel diary to check on the symptoms of the patient and a quality of life questionnaire. So we included 46 patients in this study. 35 of them were implanted, which is 76% of success rate, which goes in line with what was published in systematic reviews. We didn't see any baseline differences between patients who respond and did not respond, but we did see that 40% of non-responders had an anastomotic failure. And this is maybe a red flag that we can induce. Of course, we don't have strong evidence to say do not implant a patient who had an anastomotic failure, but be careful with them because that fibrosis you can get in the pelvis might block any inputs to restore the physiology with the sacral neuromodulation. As you can see here, the LARS score patients who at the first phase, at the crossover evaluations, patients with an on phase with the generator connected had better results than those patients with the same patients with the generator was disconnected. And when we evaluated after 6 and 12 months, we could see a reduction around 20% after from the baseline LARS score. Continence score was exactly the same. We could see a better response, a better answer to those patients with the generator connected, and the results at 6 months and 12 months was a reduction of almost 60% in the score, which was much higher than with the LARS score. And this is mainly, I think, the most important slide of the study, because you can see here how those patients with at baseline 50% of patients had more urgency. Those patients with at baseline had a better urgency episode per day. And we can see here after implantation, after the advanced test at 6 months and 12 months, those patients who had urgency, more than 2 episodes of urgency, were much less than before implantation. And also they improved sensation of complete bowel empty, and they also reduced some clustering episodes. So we can see here in this slide that the urgency part, that storage pattern, had better results than that clustering pattern that I was telling you about. And of course, this was translated into an enhancement in quality of life of patients. Those symptoms, those lines for negative symptoms in quality of life ranked in this graphic, and those functional symptoms improved with sacral neuromodulation. So the conclusions of the study were that sacral neuromodulation is safe and effective to treat large patients. Patient selection is still unclear, but I think that we're going to an incontinence pattern of LARS. Those patients who urge, those patients who have incontinence might be better candidates, but I think that we still have to offer SNM for those patients who cluster also. Also, for those patients who have a combined urinary dysfunction might be useful. I just submitted an abstract to the American meeting for next year, explaining the results we had in urinary dysfunction in this study. A little spoiler, it works. They improve their urinary function also, so that should be kept in mind. We need to talk to our patients regarding timing. We recommend this therapy after 1 year, but I think that some patients might get benefits from an earlier recommendation of the therapy. And I think that a LARS patient should not be your first patient to implant, because you can have some technical difficulties. The tissues are harder. You have more fibrosis. Sometimes the electrode does not slide really well. So get some expertise before implanting a LARS patient. That's my advice. And of course, as any other patients, you have to have adequate expectations for the patient, because some of them will not regain, they don't have rectum, some of them will not regain full continence. So I want to share ASCRS, as Joyce was telling you, we won the best paper award last year in your meeting. Was amazing, an amazing experience. And that's all, folks, from Barcelona, and I'm ready to answer any questions you might have. Thank you.
Thank you so much, Dr. Marino. That was awesome. That was really comprehensive. I will start off with the questions, since I think we're still waiting for some chat questions to come in.
Okay, great.
I am curious, after you do the implantation for SNS for your incontinence patients, just in general, what therapies do you have them keep continuing? Like, do you have them still go to pelvic PT? Like, what things? Obviously, you still want to optimize their bowel movements, but what other things do you kind of like keep the patients doing?
After we get to that point where we implant the patient, I think that all physical therapy should be done before that. If they relapse, you have to do, basically, you can send them back to physical therapy. It won't hurt. I think it's useful, but you have the possibility to reprogram the patient. Okay, the patient has to come to your office, explain what's the relapse about, because if they have diarrhea, you have to tell them, go back to the fibers, go back to, you have to start from zero again. And you can change the programming. Okay, this is more advanced, but you can take the pulse width, you can change the intensity, you can take the polarity, you can within, so you can attack and you can stimulate different parts of the nerve. Okay, so if the patient relapse, you can, that's what you should do with them.
This is another question I have, and this is more along the lines of the urine incontinence. What kind of symptoms did you see? I know that you just said the abstract got submitted, but what kind of symptoms did you see improvement with, just like from your experience?
From my experience, that's why I wanted to show you, it's the time to defer. That's one of the main things that the patients will be thankful about. Now I don't have to run. I can wait. And they some of them still wear pads and they still wear diapers. And I still use them, but I don't need them anymore. But there's sometimes they are so frightened and scared of having an episode, but that's when they, and even passive incontinence, they get back some triggering, some now I know, and I can go. Okay, that's one of the things that I tell my patients. So that's why sometimes when we talk about fecal incontinence, I think we have to phenotype it, because our colleagues from urology, they phenotype urinary incontinence. It's either stress, or it's urgency, or it's mixed. Okay, and they don't do sacral modulation for stress, or for stress incontinence mainly. They do it for overactive bladder or any other kind of problems within the bladder. They treat the bladder. They don't treat the sphincter. And we have been focusing a lot on the sphincters, but we need to treat the rectum sometimes. Okay, so that's why we need to phenotype. It's a patient complain about urgency. Is the patient soiling? It's just a small soil. Maybe if it is a soil, a little spot that they have which is really um, disturbing, but maybe they have a prolapse, maybe they have a hemorrhoid, maybe they need to correct their defecation maneuvers. So we need to phenotype, and that's what we're, as colorectal surgeons, we're not doing, phenotyping incontinence.
We do have one question from the chat from Dr. Amir Esparza, is asking, hello, can you please share the indications for pelvic floor dysfunction? For example, inability to evacuate stool.
That's a good question, actually, that I don't have the answer. If the patient has inability to discharge tools, we're talking maybe sometimes what ODS. If the patient has an isthmus, if the patient has a prolapse, that's a different sometimes problem. At least in Europe, we have a CE mark, which is basically the authorization of the like your FDA, something like that. So the S&M is not recommended for constipation, any kind of constipation right now in Europe. I'm not sure about the US. I do think that there's a specific patient in which they have anismus or hyposensitivity in direction that might get improved the evacuation disorder with S&M, but it's very difficult to find that patient. Okay, so of course, after a comprehensive physiotherapy rehabilitation, after a comprehensive medical treatment, if the patient only has that outlet issue that or hyposensitivity, I might try it, but expectations are much lower than in fecal incontinence.
No, that makes a lot of sense, especially with the results we're seeing.
Yeah.
Um,
But I think it was a problem with the clinical trials with constipation that they mixed many types of constipation. And I think that's the big mistake. There's one clinical trial from the Netherlands, recent from last year, that they found some specific benefits for constipated patients. But so I think that that's one of the things we need to develop in the future.
no, that makes a lot of sense. I think those are it for our questions from the chat. I want to thank you again, Dr. Marinello. That talk was awesome. For those of you who are still watching, yes, it is recorded and it will be posted on our YouTube channel and on Surgeon within the next week. Thank you again, Dr. Marinello.
Have a great evening. Thank
You
you for
too.
inviting me, for having me here. Take care.